We see folks from all different cultural backgrounds. It goes across the spectrum. We see people who just want to get their lives back.
We have a lot of women from a lot of different walks of life, some that are professionals, we have some that are teenagers, and then we have people who have been struggling with addiction for a lot of years. All of those groups of people can struggle with opiate use disorder, and they all need help.
Well, I think that the research really underscores the use of medication-assisted recovery for someone with an opioid use disorder. That this is a brain disease. There will be times when people will struggle more than other times, and for a provider who doesn't have an opioid use disorder, it won't look logical. And there are different triggers. It is not uncommon for someone to have a craving and use again. And we just get right back, help them get back on track with their recovery. One of the things that folks who are in recovery will tell you is, don't tell us that relapse is part of the disease. It is for some people. That just means recalibrating and getting back on track. For other folks, it's not a given. There are people who that doesn't occur for whatever reason. It just depends on neurologically what kind of healing has happened. It depends on what you had when you began, what kind of recovery capital. Just a lot of depends and different factors. Because it doesn't appear logical that you would give up so much for that drug, can end up blaming the individual rather than seeing it as a disease process. And then what do we need to do to help support the person to get them back on track, just like we would with diabetes. And I think for providers, oftentimes what they do is, because again, addiction, you can't see anything but the behaviors. And even though we may recognize that it is brain disease, it can be really easy to think that people have choice, but once addiction occurs, some of that choice goes away. And that's why medication-assisted treatment is so helpful, because it helps stabilize the brain and then allowing the person to have access to those parts of their brain that they can use to make careful, mindful decisions. But if you are just craving this and your brain is telling you you're going to die without this drug, then it becomes you're no longer in control of that. They want their life back. They want to be good moms. They want treatment.
These patients who are going into recovery a lot of times have neglected their health for many years. So just because they're in treatment for their opiate use disorder, please do not neglect their other health problems. Do not wash your hands of their diabetes because they're on methadone. They need that treatment too, and it's not one or the other and shouldn't be. Please, please, if there's anything I can say, please help them with those other chronic illnesses.
We see a high rate of individuals who've experienced either childhood trauma or trauma as a result that they've experienced as adults, either because they were in high-risk situations, and that really impacts. Sometimes there's a family history. We talk about trauma-informed systems, whether you are a substance use disorder treatment center or whether you're a healthcare provider, making sure that the services that you provide are trauma-informed and that you don't re-traumatize a person. And I think that's a key component to marry together the research on trauma and the research on addiction. We're talking about changes in the brain that really need to be addressed and need to create relationships and environments that feel safe, that are supportive, and that move people along in their recovery.
Maybe it's post-traumatic stress disorder or untreated depression, but those things need to be addressed for them to stay safe and have a healthy, happier life. They need to be honest with you, because if they are failing, it's not because that they're bad or they did something wrong. It's because that we're not treating them with the right medications. We're not addressing certain needs. And if they don't tell you that they're slipping up and having trouble, there's no way for them to help you. And by letting them know that, they can know you're a safe place to talk to.
The gold standard has been methadone, and for some folks that's the most appropriate medication, and that has to be coupled with supports, including, and I underscore, counseling. And then buprenorphine products such as Subutex or Suboxone are also medications that can be used that help support. They're just different medications. Being able to provide that service in a real coordinated way with their other healthcare providers. It may be roles that they have. It may be their cultural history. Just a number of things, but we really try and work with the whole person. And what we've discovered is just incredible things about people when you start to look at the whole person, that they're a musician. And did you know that they had a degree in this? Or did you know that they create this? Just a lot of things that about who they are as a whole person. They are not their disease. It's the subtle things such as, do you greet people by their name? Do you remember something about them? It's the kind of things that we would all want, and we know when we're not feeling respected.
So I think it's very helpful for patients to know that they have a safe place to come to when they're thinking about going into recovery, so that when they are ready to get help, that they have someone they can talk to and know that they can be honest with all the situations occurring with them. Maybe there's psychological needs that aren't being met, and if they don't tell you that they're slipping up and having trouble, there's no way for them to help you. And by letting them know that, they can know you're a safe place to talk to.
You have to have hope, and you have to provide hope, and you have to believe in that. So those are the components that I think really help to create a good model of care.
I think having a urine drug screen available, point of service care is important. That way you kind of know that the patient's taking their medication. You also know if they've slipped up. There may be issues where they will tell you they have relapsed, and it's not even in the urine because it happened, a few weeks ago, but at least gives you an idea of what's going on. I think the most important part of that is that you're kind of confirming where you think you're going. I also believe case coordination can be very helpful. That can help them as far as the housing and the food issues go, transportation, care for their children. And the other issue is having counseling available for them and making sure that they have the ability to help them get through counseling, and also helping them with mental health issues. Many patients will get into this arena, maybe it's post-traumatic stress disorder or untreated depression, but those things need to be addressed for them to stay safe and have a healthy, happier life.
If you hear in a group terms such as those people, then we know that perhaps it's not as trauma-informed and as welcoming. Terminology such as toxicology screens, they are either positive or negative, just like they are for any other kind of disease. If you go in for a urinary tract infection, is it positive for an infection or not? There's a tendency to use words like dirty, and that's a stigma that causes shame, that you somehow have dirty urine, rather than you're symptomatic of your disease. We don't use the word abuse, we use substance use disorders, because abuse says that the person purposely is abusing, when in fact it's the drug that abuses the folks that we serve. Of course, never using any derogatory terms. We like to use the term individual or the folks that we serve. It helps us to remember that we're here to help them to be a support on their journey of recovery. I think that we have moved as a society and as a healthcare system away from the days of stigmatizing women who are pregnant and considering it a criminal action. We don't see that now. We do see some remnants of the stigma. How could you do this to your baby? And what I hear when individuals state that or convey that is just a lack of understanding about the disease of addiction, that this is not a purposeful thing that this person is doing to hurt their fetus or their infant. So I think that there are remnants of that, because it is so baffling if you don't understand addiction, and it doesn't make sense. But once you make the effort to learn about it as a brain disease, then you begin to understand that these are individuals who want the best for their children. They want to be good parents. And they feel oftentimes a lot of shame because even though they understand that, they can't understand why they can't be better parents. And they keep trying and failing and trying and failing. And that's why it's really important that we intervene and help them get into treatment and help them begin recovery.